Hey everyone, and welcome. I am absolutely thrilled to have you here for today's explainer. We're taking a standalone, deep dive into a foundational framework for emergency medical encounters, pulling exclusively from some really incredible clinical and pre-hospital curriculum guides. We're going to break down exactly what it takes to effectively evaluate, communicate with, and treat a patient when you're under high pressure in emergency situations. Okay, let's dive into this. Today's syllabus is designed to follow a logical, progressive framework. We'll start with foundational EMS vocabulary, then move on to the first patient encounter. After that, we hit patient assessment and vitals, followed by clinical scenarios and OSEs, and wrap up with takeaways and next steps. Foundational EMS vocabulary. Speaking the language. Before you can even lay hands on a patient, you've got to master the clinical language of emergency medicine. It's essentially the shorthand for rapid communication. Think about the inside of an ambulance. It's a tight, incredibly high-stress workspace, right? When you're in the back of that rig, bouncing down the road at high speed, there is literally zero time for confusion or drawn-out explanations. The vocabulary we're about to cover is exactly what allows paramedics, EMTs, and doctors to function seamlessly as a unified team in that kind of intense environment. So the first term you absolutely must know is triage. Triage is just the sorting of patients to determine their priority for treatment during an emergency or mass casualty incident. Imagine arriving at the scene of a massive multi-car pileup. You simply don't have enough hands to treat everyone all at once. Triage gives you a systematic way to figure out who needs immediate, life-saving interventions right this second and who can safely wait a bit. It is the very first, critical step whenever resources are stretched thin. Next up is mechanism of injury, or MOI. This simply refers to exactly how a specific injury occurred. But why does this actually matter? Well, understanding the MOI gives you what we call a high index of suspicion. This basically means that by understanding the raw physics of an accident, say a high-speed steering wheel impact to the chest, you can anticipate severe, unseen internal injuries, even if the patient looks perfectly fine on the outside. Our third essential term is crepitus. Crepitus is the sound or the physical sensation of bone ends rubbing together. I really want you to practically imagine feeling that grinding, gritty sensation right under your hands during a physical trauma assessment, or even hearing that terrible crunching sound. It's kind of an abstract textbook term until you connect it to that visceral reality, which makes it highly memorable when you're on the hunt for hidden fractures. So, wrapping up our first block, your core takeaway is this: master emergency terminology. It's not just about passing a multiple-choice vocabulary test. It's the critical, everyday tool you use to accurately assess dangerous scenes, communicate lightning fast with your team, and anticipate unseen injuries. Block 2, the first patient encounter, communication as a clinical tool. The truth is, all those excellent clinical skills mean absolutely nothing if you can't effectively communicate with someone who is injured, terrified, or even angry. Initiating contact under pressure demands a structured approach. First, introduce yourself clearly so the patient knows exactly who you are and what your role is. Second, gather accurate personal details. And third, establish the chief complaint concisely. You really need to know exactly what is bothering them the most right now. It sounds super simple, but maintaining this kind of structure during a completely chaotic emergency is a vital skill. Let's apply this to a specific, highly realistic scenario straight from our source material. Imagine a 54-year-old businessman who tripped and fell getting off a bus. He's in pain, a nurse practitioner has already told him he doesn't need an X-ray because there's no bony injury, and now he is aggressive and loudly demanding to see a senior doctor. How do you handle this? Well, you have to maintain a totally open mind and not harbor preconceived ideas, because honestly, even obnoxious patients can have serious missed conditions. You've got to stay calm and professional. And, crucially, you need to explain your clinical reasoning without hiding behind alienating medical jargon. Don't tell him he doesn't have a fracture. Just tell him it's not broken. Take a breath and explain the specific rules exist to safely determine who needs an X-ray and that his care is based on these strict guidelines, not laziness or ignoring his pain. Tying this right back into patient safety, another key term in communication and history-taking is contraindication. This is a specific situation when a certain intervention or medication should absolutely not be used because it could actually harm the patient. For example, if that angry businessman is demanding a specific painkiller, but your careful history-taking reveals he's allergic to it, that allergy is a hard contraindication. In that moment, your communication skills literally just prevented a medical disaster. So the crucial point is this:
Clear communication and active listening are just as vital as any of the medical equipment in your bag. They are the absolute keys to accurate history taking and to successfully de-escalating tense, aggressive encounters, so you can safely and effectively treat your patient.
Block 3. Patient Assessment and Vitals. The Clinical Examination. Now that we've got a handle on how to talk to our patients, we're shifting our focus over to the hands-on physical assessment. Think of the caduceus, that universal symbol of medicine and clinical intervention. It perfectly represents our transition from that initial verbal encounter into the heavier, highly structured medical assessment protocols. This is the moment where we actually lay hands on the patient and figure out exactly what is going wrong inside their body. The absolute bedrock of any emergency assessment is the primary survey, which you probably know as the ABCDE sequence: airway, breathing, circulation, disability, and exposure. Now, you do not skip steps here. This rapid sequence is explicitly designed to immediately identify and treat life-threatening conditions in a very specific order of priority. For instance, if you identify a tension pneumothorax, where air gets trapped in the chest cavity during the breathing phase, you treat it immediately. You don't just note it and move on to check their circulation. You fix the immediate life threat first, period. Once the patient is stabilized and those immediate life threats are completely cleared, we move on to the secondary assessment. This involves a much more focused, comprehensive head-to-toe physical exam. You're evaluating specific signs and symptoms, and you are continually monitoring their core vital signs. A huge part of this phase is trending, which means reassessing the patient repeatedly to spot subtle changes or deteriorations over a period of time. Are their pupils changing? Is their heart rate slowly creeping up? Trending catches all those little things that a single one-off snapshot completely misses. Our takeaway for Block 3 is absolutely foundational, so lock this in. Always follow the ABCDE sequence strictly. You must eliminate those immediate life threats before you even think about focusing on localized injuries like a broken arm or a nasty laceration. It's life over limb every single time. Block 4, Clinical Scenarios and OSCEs, putting it into practice. All right, now we get to test everything we've learned through objective structured clinical examinations, or OSCEs. This is the arena where theory meets practice under the very watchful eye of an examiner. Let's pose a question to kind of tie this all together. How do you assess that exact same 54-year-old demanding patient we talked about earlier who has a suspected ankle injury? See, it's no longer just about de-escalating his anger. Now you have to perform a flawless practical musculoskeletal examination while maintaining that top-tier professional communication. To pass any practical OSCE procedure, you really need a strict mental checklist. You can't just go through the physical motions. The examiner is actively grading your clinical awareness. You must know the indications, meaning why are you doing this? You must know the absolute and relative contraindications. When should you absolutely not do this? You have to anticipate early and late complications, knowing exactly how to deal with them if they pop up. And finally, you have to be able to present your findings clearly and confidently to the examiner. And this brilliantly illustrates what a focused musculoskeletal exam actually looks like in practice, whether you're looking at a shoulder, a wrist, or an ankle. You meticulously inspect the joint from the front, the sides, and from behind. You're constantly assessing for swelling or any sort of deformity. You test the nerve and vascular supply to ensure that blood is flowing and nerves are fully intact past the injury site. Finally, you take all of these clues to formulate a solid differential diagnosis to present to your examiner. Our final block takeaway really cements this whole holistic approach. In simulated clinical exams, and for sure in real life, procedural skill is just never enough on its own. It must always, always be paired with a crystal clear understanding of the risks, the potential complications, and an unwavering focus on patient safety. Block 5, Takeaways and Next Steps, continuing the clinical journey. We have covered an incredible amount of ground today, building a really solid, modular clinical framework for emergency encounters, from mastering the rapid-fire vocabulary of the ambulance to the vital art of de-escalating an angry patient, to the life-saving ABCDE primary survey, and finally proving those skills in an OSCE setting. But I want to leave you with one final provocative thought. You know the vocabulary. You understand the communication techniques. You've memorized the primary survey. But are you prepared to execute all of this flawlessly under the extreme pressure of a multi-casualty major incident? That is the ultimate test of an emergency provider, and it perfectly sets the stage for the next critical chapter in our curriculum, major incident management. Thanks so much for learning with me today, and keep practicing those skills.